Good evening to all participants, PG students. Thank you so much for joining us for this wonderful the Nephrology Postgraduate Educational Program. It's an initiative, educational initiative by Nephrology Division of RPG Life Sciences. So I welcome all of you to third session of this series on clinical transplant immunology. So before I could introduce the speaker, I would like to just highlight the program and the objective of the program. So the objective of this postgraduate educational program is to connect the best of faculties in nephrology all across the India to these PG students. Physically it won't be possible. So we have chosen an online platform for this. And we are aiming for a session every month. So there would be series of 7 sessions. Today we have third of that series. And 2 sessions would be based on the PG students' recommendation. So after each and every session, we would be having exam, or you can say assessment. And based on those assessment, you would be getting the rewards also. Post program, you would be getting the link for the exam assessment as well as the scientific notes of that program. So once we finish the 7 sessions, you would be eligible for the certificate of participation as well as special recognitions, and which would be authorized by the honored faculties throughout the program. So we had already completed the kidney transplantation past and present, management of long-term post-transplantation and complications. And today we would be having a talk on clinical transplant immunology. So the first session, as you are aware of, we were blessed to have Dr. Professor Chako Jacob, and he had briefed upon the kidney transplantation past and future and present. The video is available on YouTube, but today, after finishing third session, you will be getting the video link for all 3 sessions together. Second session, we had our honored speaker, Dr. Siddhini sir, from the Manipal Hospital, Bangalore, and he had briefed on the management of long-term post-transplant complications. So its video is also available. So today, for session 3, we are honored with the presence of speaker Dr. Sishir Garg sir, and he would be speaking us on clinical transplant immunology. So I officially welcome you, sir. Thank you so much for giving us this time, and you're going to share the session. Before I would hand over the session to Dr. Garg sir, I would like to introduce him. It's my pleasure to introduce him. Presently, he is associated with Muljibhai Patel Hospital as a chairman of Department of Nephrology. He had done the fellowships from the renowned institutes like International Society of Peritoneal Dialysis and the International Society of Nephrology. He has more than 40 publications in peer-reviewed index, national and international journals. And he was a part of more than 14 drugs, chemical entities at Muljibhai Patel on different phases of the trial. He has presented, he's a voracious speaker, presented several papers at national and international conferences. He was called as a guest speaker for many seminars and workshops. And he is member of several academic bodies. To mention here is International Society of Nephrology, American Society of Transplantation, American Society of Nephrology. So he has very wonderful career and it's serving the patients. So it's our pleasure to have you, sir, with us. I would like to hand over session to over to you, sir.
Thank you, Dr. Mangesh, for the kind introduction. It's my pleasure also to be part of this series of talks meant for the postgraduate students. And I think it's a very good initiative, bringing both the faculty as well as students together. And I look forward to this session. The task given to me was to talk about the immunobiology of transplant rejection. As we all know that whenever we do a kidney transplant, the life of a transplant is finite. And as you can see that way back in 1989, if you did a cadaveric transplant, the 1 year graft survival was less than 80%. So 20% of the attritional grafts were lost. Though it has improved significantly over the coming years, and now in 2009 and even 2020, the first year graft loss is about 5%. Over the subsequent years, usually the graft loss is about 6 to 7% in the cadaveric transplant. The similar story is there in living donor transplant. The first year graft loss used to be about 8 to 10%, which has now come down to less than 4%. But still, over the years, there is an attrition of about 4 to 6% of grafts are lost every year. So half-life of the graft is somewhere around anywhere from 8 to 12 years. Now, why do we lose our grafts? So if you see the cause for the graft loss, most of the graft loss which are lost in the initial period, that is the first 100 days of transplants, are because of non-function, primary non-function. Sometimes the abnormalities are not known. And initially, there could be some degree of T-cell rejection. And subsequently, most of the graft loss over the years is because of antibody-mediated rejection. Of course, some grafts are lost because of recurrent glomerulonephritis, and some are lost because of BK virus, and some because of mixed rejection. So overall, if you see a large percent of the graft loss, despite very good immunosuppression, we lose these grafts to either a T cell in the initial period and to the antibody-mediated rejection in the subsequent period and to the mixed rejection. So it is very important that though we have made significant advances in the immunotherapy for transplant, preventing transplant rejection and treatment of rejection, we still have a long way to go. And it's good to understand how does the biology of a transplanted graft behave. So what I plan to do is to initially have the components of the immune system involved in kidney transplant rejection. How does the body recognize that it is an allograft, and what are the mechanisms of injury? If you put in the graft between two non-identical individuals, is always rejected. So when you graft from the same individual or a genetically similarly individual, it is also known as syngenic graft or isograft, the graft is accepted, also known as an autograft. If you transplant skin from an allogenic recipient, allogenic meaning that they are genetically unrelated but of the same species, in the first set of, if you do it the first transplant, the rejection happens over a couple of days. But if you do it again, then the rejection is much faster or accelerated. That is because of the memory cells. The third category is a xenotransplant, where you transplant from organ or tissue from a different species to another species. We will talk today mostly about allotransplantation because xenotransplantation will be a talk by itself. Now, what is the timeline of the allograft rejection? And this I've taken from your textbook of Peter Morris. If you see that initially there is an ischemia reperfusion injury, because when we harvest the graft, initially there is some degree of warm ischemia. Then you cool the graft, then there is again second warm ischemia. And so initially there is a warm because of ischemic reperfusion injury. And this is usually because of the innate immune response. Subsequently, you get a T-cell mediated rejection. Then you get an acute antibody-mediated rejection if it is a naive transplant that is not exposed to the antigens prior to it. And then over the years, you get a chronic antibody-mediated rejections. And different players actually play a role in them. And we shall see how these players play a role in the rejection process. So as you understand that there are two components of the immune system. One is what is known as the innate immune system, and another is known as an adaptive immune system. Innate immune system is something which the organism responds to any injury or any infectious agent. And evolutionary, the earliest system to develop was the innate system. The components of the innate system can be both. They can be proteins and they can also be cells. And the common proteins involved are the complements. And the cells involved are the neutrophils, the macrophages, the dendritic cells, and the NK cells. Whereas an adaptive immune system, as you would understand, is something which the body develops after the first encounter. And the group of the innate system is important for educating the T cells and the B cells to mount a response to the foreign antigen or to a pathogen. Now, how does the body recognize that something foreign has entered into the body? And this was not understood for many years, but in the last 2 decades, there has been a lot of understanding as to how does the body recognize that there is something foreign to it or non-self. So the first encounter is that whenever there are pathogens or whenever there are damage to the cells, these release a certain amount of proteins or polysaccharides, and these polysaccharides and proteins, they are recognized by the receptors present on the cells of the immune system, but what is known as the pattern recognition receptors. And the pattern recognition receptors are of several categories, but the most famous and the most studied are the toll-like receptors. There are also receptors in the cell, which are known as the nodes or NLRs or inflammasomes. So if the antigen enters into the cell, they can still be recognized. And then once these are recognized by it, it goes to the information is transcribed to the gene, and from there the cytokines are released. And this set of cytokines which are released, either they can have complement activation, they can release chemokines to attract the cells, and they may sometimes engage directly into clearing the cells. And then they also are important to send messages to the cells of the adaptive immune system to generate further responses. So these responses are non-specific to any injury. So they can be either pathogen, that is the pathogen-associated molecular patterns, or damage of the cells or damage-associated molecular patterns. The potential adaptive immunity by itself does not reject the graft. So innate immunity, though important as the first response to any of the foreign antigens, but by itself cannot really reject a graft, and it would need the help of the adaptive immune system to mount a rejection. But why is this important? Because if you have a more damage in the graft, there is going to be an increased recognition by the innate immune system, and similarly an increased information to the adaptive immune system to mount a rejection and reduce the survival. If you see here, in the same degree of ageism, even if there's a zero HLA mismatch, the cold ischemia time is longer. That means there's a more damage to the graft, the outcomes are poorer. Of course, if the HLA mismatches are much more, and if there is a prolonged cold ischemia time, more injured tissue is available for the innate immune system to send responses to the adaptive immune system, and therefore the graft survival is reduced. So all in all, we must realize that we must reduce as much as possible the innate response. Currently, there are several methods which are being done to either modify the graft to reduce the response of the innate immune system, though currently it's not clinically available. The second most important thing is for the T cell activation. As I said, that for after the innate immune response, the T cells have to come into play to mount a response to the foreign antigen, that is to the allograft. T cells are essential for the alloimmune response, that animals without T cell are unable to reject the graft. There were several studies done which showed that if you develop an animal with an absence of a T cell, they do not mount a rejection. But if you infuse T cells into these animals, they would mount a rejection process. So it became very crucial that T cell is very important for rejection. And therefore, we see the first 3 decades after the 1950s and 60s when transplantation started, a lot of studies were done on T cell, and we tried to reduce the response of the T cells so as to overcome the alloimmune response. It's only later on that it was recognized that antibodies are equally important, which I'll see in the subsequent slides. Now, the question is that how does a T cell recognize the antigen that is a foreign? So, and how it is activated, we shall see in the coming slides. So once the allograft is put into the patient, the donor leukocytes and the antigens are set. Now these antigens which are set and the leukocytes which are passenger leukocytes, they travel to the nearby lymph nodes. Initially, when the graft is put in, at times because it is the lymphatic systems are not actually anastomosed, most of the action even takes place in the spleen. Subsequently, even the draining lymph nodes become active and the action takes place in nearby lymph nodes. So how does it recognize? So the first important thing is that there are donor leukocytes, and these donor leukocytes contain the antigen-presenting cells. Usually these are dendritic cells. These dendritic cells actually contain the unprocessed major histoconvertibility complex on its graft, and they present the antigen directly to the T lymphocytes. So what is this known as direct recognition? That these are the donor antigen-presenting cells, and these are the T lymphocytes. However, there's another mechanism also where it can have an indirect response. And what happens that the antigen which is recognized by the T cell as a foreign antigen is usually the antigens of the HLA system, that is a human leukocyte antigen system. And because these proteins are polymorphic, and polymorphic proteins are proteins which the recipient does not know if it does not have those proteins, and it will mount a response to those polymorphic proteins. So these recipient antigen presenting cells can take up these MHC antigens, take it up, and in the context of the HLA molecules, usually it is the class 2 molecules where it presents it to the T cells. So these are processed allogenic peptides from a donor MHC bound to the self MHC. Because it is important to note that the T lymphocyte will only respond in the context of the MHC. Here it responds in the context of the foreign MHC, which it to some degree does, but it responds very well in the context of self MHC. So it will not respond to a free-floating antigen somewhere in the serum. It will only respond, or T cell receptors will only recognize if the antigen is presented in the context of the HLA molecules, either class, the CD4 will respond in the case of class 2 and the CD8 in the case of class 1. There's an increasingly recognition is that there is another mechanism also known as a semi-direct. In semi-direct, what happens is that the donor antigen presenting cell sheds its HLA molecules along with the antigens. And these are in the form of exomes. Exomes are actually a tiny membrane-bound vesicles. These membrane vesicles are then taken up by the recipient antigen presenting cells. Once it's taken up by the recipient antigen presenting cells, it is processed. It is then taken to the surface, and on the surface it is presented as the donor MHC molecule to the T cells. So this is a patient's own, and this is from the donor, and therefore it is also known as a semi-direct mechanism of presentation to the T lymphocytes. And if you see that in the initial part, and the very first when the graft is put in, the direct and semi-direct allorecognition becomes important. And as time goes by, indirect allorecognition, that is recognition by the recipient's antigen presenting cells, becomes important. Once the antigen is presented to the T cells, it is shown, and as we all know, that this engagement of the antigen on the donor antigen presenting cells and the T cell receptor of the CD4 cells by itself is not sufficient for the naive T cell to become activated. It requires signal from the co-stimulation. And there are numerous co-stimulatory signals, but the one which is best studied is the B7 and CD28. CD28 is present on the CD4 cells, and the B7 is present on the antigen presenting cells. In absence of the co-stimulation, the activation of T cell does not happen. Another important co-stimulator signal is CD40 and CD154. And as you would all recall from your current therapy, belatacept is actually a CTLA4. CTLA4 is another protein which engages with the B cell and prevents the CD8 from engaging with the B cell, and therefore does not provide the co-stimulatory signal which would be necessary for the T cell activation. Once the T cell is activated through these two signals, it releases the cytokines known as interleukin-2. Now, interleukin-2 is actually a cytokine which has an autocrine effect and also has a paracrine. Autocrine effect meaning it acts on the same cell itself on which it is released and also acts on the neighboring cells. And this leads to proliferation of the activated T cells into multiple cells. Moreover, both from the donor antigen presenting cells and cells from the activated T cells, several cytokines are released. And this several cytokine release can change the character of the activated T cells. They can either form a T helper cells type 1 or T helper cell 2, Th17 or T regulatory cells. And this is not completely understood what are the real mechanisms by which you can get into different T cell types. But these can also change depending upon what stimulation is available to them. If the Th2 gets too much stimulation for interferon or interleukin-2, it can change its character from Th2 to Th1 also. So this interchanging can also happen. Many of these cells have got a very specialized function. And important to note here is that T regulatory cells is one cell which actually will suppress the degree of activation and will lead to what we call dampening of the effect. Because in every system in the biology, there are activators and there are suppressors, because we don't want an unproliferated activation. And T regulatory cells are important for suppression. Today, I won't discuss much about T regulatory cells because for tolerance and other things, it will be a talk by itself. So as I just alluded to, that there is a signal 1 where there is engagement of the dendritic cell to the T cell through the T cell receptor. Then there is a signal 2, which is an activating signal. And there are sometimes also inhibitory signals also are there. And once these two signals are there, they go downstream. So once there is signal 1 and signal 2, they both signal together, then have an intracellular pathways. Now, intracellular pathways, there are several pathways. Again, I won't talk in detail about it, but just to allude to some of those pathways, calcineurin is one important pathway, which then actually blocks the, activates the NF80. NF80 is the phosphatase pathways, which then goes to the gene. It replicates the genes for several cytokines. And one of the important genes that it replicates is the IL-2. Now, this IL-2 is released over here. And then this is interleukin 2. Interleukin 2 can, as I said, it can act in autocrine fashion, can bind to the CD25 or IL-2 receptor. IL-2 receptor is also known as CD25. It binds to it, usually to the alpha component of CD25 receptor. Again, it has downstream pathways where it activates the mTOR pathway. Okay, so there are several ways by which, so these signal 1, signal 2, signal 3, all the signals are important to understand because a lot of pharmacotherapy is based on this signaling. Now, as I said, once the naive T cell, actually because of the interleukin 2 and receptors of interleukin 2 starts proliferating, then they have to really start working hard. So some of them will become effector cells, that is, they'll start damaging, and some of them will go to the memory. Memory is important because the time response is much shorter if you have a memory T cell, whereas in a naive T cell, it takes a longer time, which we shall see in subsequent slides. So as I just alluded to in the previous slide, that several pharmacotherapy has been designed to inhibit it. And in the signal 1, we have got the anti-CD3 monoclonal antibody. In the past, it was known as OKT3. OKT3 was important both for prevention and treatment of rejection. But because of several cytokine storm, this therapy is now no longer used. But when I was studying in 97, 96, we used to use this for treatment of unremitting T cell rejections. Now we got better therapy, so we don't use that. But now again, this therapy is coming back in a more humanized anti-CD3 monoclonal antibody, and you will see some of it in the near future. Another important for the signal 2 blockade is a CTLA4. CTLA4 is actually combines with the CD28, does not allow, it's combines with CD80 and 86, and does not allow the interaction of CD28. And this is what is belatacept. And belatacept, as you know, is a drug which has been very successful, and though currently not available in our country. And we were involved in some of the earlier trials in belatacept. We still have one patient on it, and he's doing very fine after 14 years of transplantation. So in the downstream pathway after signal 2, as I said, that the calcineurin are important for phosphatases, which dephosphorylates the NF80. It goes into the cell, and cyclosporin and tacrolimus block the calcineurin. And blockage of this calcineurin will not allow the further generation of the cytokines important for cell proliferation. Similarly, the antibodies to where the interleukin 2 acts, that is the anti-CD25 monoclonal antibody, also known as Simulect in the trade, blocks the proliferation of the T cells. So this is usually given at the time of transplant to prevent the activation of T cells and prevent them from damaging the graft. Then there are downstream pathways, as you all know, the mTOR pathway, the mammalian target of the T cell, mammalian target for rapamycin, and where the sirolimus and everolimus acts. Then it goes into a cell cycle. Cell cycle inhibitors are usually azathioprine as well as mycophenolate mofetils, where they act. And these nucleotide synthesis, where the MPUH and FK7, but this was no longer developed. But this, and there are other pathways, that is JAK inhibitors, FTY720, which actually was important for altered this. Some of the molecules are important for the cell to migrate into the different areas. And one of the receptors for migration is the S1P receptor, which is FTY720. Initially, it was developed, but subsequently the results were not so good, and there was increased thrombosis, and this was no longer developed. So FTY720 is no longer available. Anti-CD52 monoclonal antibodies is actually is used for it is present at both the CD4 and CD8 T cells, and therefore it can cause severe depletion of the T cells. And this is currently the I'm just missing the name of the drug, but it is currently available, not available in our country. but it is available outside where you can really deplete the anti-CD52 antibodies. Okay, so these are, in this way you can have several targets to where you can use these drugs. Now, once the T cell is activated, what does it do? It then has got its goes from the lymphocyte back to the graft. This is the endothelium, and because the chemokines which are released from the graft attracts the T lymphocytes over there. The T lymphocytes will migrate into the vessel, and then they come out into the interstitium. This is the vessel, and they come out into the interstitium. They go to the tubular cells, where actually the CD8 T cells, which is the cytotoxic T cells, releases the enzymes and perforins, and these causes holes. Literally, they cause holes in the wall of the T cells and the tubular cells. And then once they are there, they can damage and they can break the T cells. And you can see the T lymphocytes over here within the tubular cell. And there are two types of cells. Actually, the CD8 is cytotoxic T cells, which releases the perforin and enzymes and cause direct cytotoxicity. Whereas the CD4 cells actually releases interferon, and these interferons then bring in macrophages and other neutrophils, which can also damage the graft. So CD4 is mediated is something like a delayed type hypersensitivity reaction, whereas CD8 mediated is direct cytotoxicity to the cells. As you all understand that the endothelial cells have both all the nucleated cells have the class 1 antigen, and some of the cells like the lymphocytes have class 2 cells, class 2 antigens also present on them. The endothelial cells can also mount class 2 antigens, especially if they are stimulated. So in summary, how does it all happen is that once you put in a graft, the antigen presenting cells move to the secondary lymphoid organ. There they educate the T cells. Some of them go to the memory. Some of them they convert to the effector cells, that are CD8 and CD4 cells. They come back to the graft, initiate a rejection process where they cause tubulitis, direct tubular injury. And they also can cause intimal arthritis because, as I said, that the first point of contact is the endothelial cells. And they also have the class 1 antigens, which is recognized by the CD4 and CD8 T cells, and the class 2 antigens, which is recognized by the CD4 cells, and they cause inflammation of the vessels and cause arthritis. And so depending upon the response, they can get interstitial hemorrhages. And the macrophages, these are brought in by the CD4 cells. It tells the macrophages to come in and also mount a rejection process. Now, how does this evolve in the thing? It is difficult to study periodic biopsies in a human allograft, but it has been extensively studied in animal allografts. So these are in the animals lab. So these are isografts. Isografts, when you put in, that means that they are genetically identical. They literally have no change over the 7-day or 21-day period. But if you put an allograft inside it, the response starts coming in by day 3, and by day 7, you start seeing tubulitis. And by day 21, if it is untreated, it becomes quite severe and you might completely lose the architecture of the graft. So these are the changes which are seen. So many times in the past, just to give a historical perspective, when the therapy for rejection was not very efficient, some centers around day 7 to 10, they would dose them with extra dose of methylprednisolone, anticipating that some degree of rejection would happen. With very poor immunosuppression, which was there in the early 70s, about 50% would have an acute T cell mediated rejection. After the introduction of cyclosporin and cyclosporin, the rejection rates have really gone down. Otherwise, it was quite often used. People would use between 7 to 10 days and increased doses of steroids. So as I said, that depending upon the degree of response, you can get a borderline, a very mild tubulitis, some moderate tubulitis, and severe arthritis, and you can get incomplete rejection. Untreated, the graft will undergo thrombosis and would be rejected. So these are just to show you an examples that these are the interstitial cells which you see here, and this is actually a cell within the tubular cell known as a tubulitis. The definition of tubulitis, the cell within it, and this is, of course, these are chronic changes in a very persistent rejection. These are acute changes where you see the T cells rolling over to the endothelium. And the pathologists like to call the rolling endothelial T cells over the endothelium as a sign of significant rejection. The second set of is an antibody-mediated rejection. So we talked about T cell rejection and B cell rejection. We'll now talk about. Now there are several antigens to which we can develop antibodies. We have naturally occurring antibodies to blood group antigen. It's the A, B, O blood group antigens, and therefore we do not do transplants we don't cross the ABO barrier unless you're doing a special protocol to do an ABO incompatible transplants. These ABO antigens are expressed on the endothelial cells of the kidney also, and therefore you do have naturally occurring antibodies. You can mount a rejection. However, just to make a point, that the rhesus antigen, that is the Rh antigen, is not present onto the graft, and therefore it doesn't matter whether the patient is Rh positive or Rh negative. And in context of transplant, we don't look at the Rh antigen at all because they are not present on the kidney tissue. The most important antibodies are against the donor HLA antigens. That is, we all know HLA antigens. We have class A and class 2. And in class A, we have A and B and C. And class 2, we have DR, DP, and DQ. Now, all these antigens are polymorphic. That means different individuals have different antigens. And therefore, you will mount antibodies to them. There are other antibodies which are important as endothelial antibodies, MYC and angiotensin II receptor antibodies. But these we will not discuss much, and most of the time we will spend on the allo antibodies because this is the most polymorphic antigens in the human system, and antibodies against them are very important for graft rejection. Now, how does the B cell come into the play? As you all know, that how does the B cell get actually educated? Now, B cells, all this action happens initially in the spleen or in the lymph nodes. So once the soluble antigens, that is the HLA molecules, reach to the B cell, these are the, if you see a lymph node, just imagine this is a lymph node, these are the efferent areas where the lymph drains into the lymph node. And you can get a soluble alloantigen over here, or the dendritic cell can bring the antigens to the B cells. Now, once the B cells, you bring antigens to the B cells, these B cells already have got receptors to which it recognizes these antigens. Once these antigens are recognized, they are actually taken up by the B cells. Once they're taken up by the B cells, unfortunately, the action between dendritic cells and the B cell alone is not important for the B cell to start producing tons of antibodies. It requires help from T cells. Without the help from T cells, the B cells cannot produce antibody. And that's why we said that if the T cells are absent in an animal, they don't mount an rejection because T cell help is very, very important. So once this B cell comes to, these B cells actually lie in the cortical area of the lymph node, whereas the T cells lie usually in the paracortical and then into the medullary area. This is the junction between the cortical and the paracortical area where the B cells actually then present the antigen which they have acquired, either soluble antigens or the antigens from the dendritic cell. They present it to the T helper cells. T helper cells, along with the co-stimulatory signals, primes this B cell, and then the B cells start proliferating and they form short-lived plasma cells or long-lived plasma cells. Important note is that a lot of this education then continues. Both these B cells then move into the germinal center, and also the T cells actually acquire CCX5, which helps them to guide to go to the germinal center. In the germinal center, the T follicular helper cells, which help the B cells to multiply. Now, these B cells, some of them will form T regulatory cells or regulatory B cells. Some of them will form memory B cells. Some of them will form long-lived plasma cells. That means they are very long-lived. Now, important to note is that why is it very difficult once the patient has memory to the antigen to eradicate that? Because these memory B cells, they lie in the niche of the bone marrow or in the lymph nodes where most of the therapies don't reach. They are inactive, and therefore it is very difficult to eradicate the memory B cells. And therefore it is very difficult to develop tolerance once you have exposure to the HLA antigens. And so once these B cells start to convert to the plasma cells, they secrete antibodies, and we shall see how these antibodies damage the graft. Again, as I said, that the B cells require a lot of help from the T cells. And they not only require help from the T cells, but there is a lot of crosstalk happening between B and T cells. And there are several cytokines. And just to tell you that one of the important cytokines is an IL-6, which you would have known in the COVID times. It is released by the follicular dendritic cell and also by the B cell, which acts onto the T cell, again activates the T cell. And therefore, a lot of the therapies are done, the T follicular helper cells for the chronic rejection are using anti-IL-6 therapy, which you will hear more and more in the subsequent years to come. What is the role of some of the other activating cells, that is APRIL and the BAFF? These are all very important for the B cell activation. But in the context of the kidney transplantation, right now, a lot of these, though these therapies have been tried in lupus and other rheumatological disorders, but currently in transplantation, anti-BAFF or anti-APRIL therapies are not much studied. But I suspect some of them will be studied in the time to come. So just to summarize again, once the naive B cells come in contact with the T follicular helper cells along with the dendritic cells, they get activated and they can form memory and they can form short-lived the antibody producing cells, or they can produce long-lived and then they can produce plasma cells. Important note is that if there is a non-sensitized recipient, it must require a lot of help from the T cells and dendritic cells to do that. And therefore, the antibodies don't come into play if the patient is not sensitized. So if the patient has not had sensitization, that has not had any previous transfusions, pregnancies, or previous allografts, usually the antibodies become a problem after 7 to 10 days or maybe beyond that. Usually not a problem in the early time. However, if the patient is sensitized, the memory B cells kick in, and these memory B cells can then rapidly recognize the antigen directly. They don't need too much of the help from T follicular helper cells, and then they can mount a very large antibody. These arrows indicate the degree of the breadth of the arrows indicate, as by the article, to show that a number of B cell producing clones that they can produce, a large amount of antibodies can be produced. And therefore, if you're highly sensitized, you might, and if you're not recognized, you can develop hyperacute rejection. Fortunately, we can detect those antibodies using the tests, and the hyperacute rejections are very uncommon. But if they're very, very low quantities or very, very low, then they may not be detected. Even if they're detected, they may go ahead and do a transplant or do desensitization. So this is the difference between a sensitized patient and a non-sensitized recipient. How does their B cell work? Here, you don't require the help of a B cell. The response is very, very quick. Now, once these antibodies are there, how does it really affect the graft? So how do the antibodies damage the graft? So there are essentially three mechanisms by which the antibodies can damage the graft. The antibodies can go to directly bind to the because these are anti-HLA antibodies, the class 1 antigens are expressed by endothelial cells and tubular cells. So they can bind mostly because they come in contact with the endothelial cells. They bind to the endothelial cells, and then they can directly result into some degree of damage to the endothelial cells. But more often, these antibodies, which we are bound to them, they would activate the complement component, that is the classical complement pathway would get activated. And then this classical complement part is activated, it can damage they produce the lytic proteins, that is C5, B9, and then these can damage the endothelial cells. There's another important mechanism which is increasingly recognized is the engagement of antibody-dependent cytotoxicity. And these antibodies, they can actually bind to the receptors of the NK cells. Now, these NK cells then release interferon and granzyme, and these are directly toxic to the endothelial cells. And even they can bring in macrophages and polymorphonuclear leukocytes to the graft site. And by engaging, the antibody will engage with the receptors on the polynuclear neutrophils, macrophages, and NK cells, and then damage the graft. So these are several mechanisms by which the antibodies can damage the graft. Important to recognize is that depending upon the amount of antibody, depending upon their ability to engage different mechanisms, this AMR is a dynamic process that might have an acute rejection. If it is a very low grade, it might form chronic lesions and then eventually lead to chronic graft dysfunction. So this is just to tell you that not all antibodies will immediately damage the graft. They may have slow injury, or and then gradually damage the graft, but they will keep it nibbling onto the graft. So how to detect the footprint of antibodies? One important thing is that, as I said, the complement activation, one of the pathways. And once this complement is activated, as you know, that it's the classical pathway, it goes through C1, Q, C4. C4 is divided to C4b, that is a labile thioester, which then forms a very stable C4D split product. Now, this C4D split product forms a very strong bond with the endothelial cells. And when it bonds to the endothelial cells, it remains very stable. It's a very highly stable covalent bond. And therefore, C4D remains as a footprint and telling you that if you detect C4D, that antibodies have visited the endothelial cells and have possibly attacked and damaged them. So another important thing I just want to tell you is that the evidence to show that there can be C4D negative antibody-mediated rejection. Now, these are non-complement fixing IgG. It can cause chronic transplant arteriolopathy. This has been studied in double knockout mice, which are knockout for RAG1 and C3. That means that there's no complement activation happening over here. And despite this, when you give them antibodies to these animals, they engage the NK cells. As I showed you in the previous diagram, they can engage the NK cells, and then they start damaging the graft. So a portion of the antibody-mediated rejection may be C4d negative, and still they can be damaging to the graft. What about the pathology? Very briefly, you might have a session on the pathology to tell you that once this complement is activated, they can go into the peritubular capillaries, they can get the lymphocytes over here, they can activate the directly damage the endothelial cells. These releases the lot of platelet aggregation molecules, von Willebrand factors, and if there's a very severe acute activation, then you can get thrombosis of the graft. This again to show you that the lesions in the peritubular capillaries, you find this cells which tell you that probably the antibodies are started playing a role. And then as the lesions advance, you can see the footprints are seen by the C4d staining. And these antibodies, as I said, they can have repeated injury. So on a chronic lesions, you can get multi-layering of the basement membrane. So whenever the endothelial cell is damaged, it lays down a basement membrane. And again, repeated damage will lead to repeated laying down of the basement membrane. And here, you can see that these are multiple layers of the basement membrane, telling you there has been a chronic damage to the graft. So these are lesions of the chronic antibody-mediated rejections. These are more often seen in acute situations. Again, the same injury can happen in the glomeruli, and you can get transplant glomerulopathy, where you can get proteinuria, and there is a C4d deposition, but there are no other immunoglobulins seen. And this is how you differentiate from MPGN, where you get also a double contouring. And this you see a double contouring because a new basement membrane has been laid down. So what are the targets where we can use to dampen the effect of the B cells? So obviously when B cells are important for antibodies, so if you think that antibody is responsible for the rejection, so one could use an anti-B cell therapy that, as you all know, you can use rituximab or obinutuzumab. There are several of the anti-B cell antibodies. It is especially against the CD20. One could use a co-stimulation blockade. Co-stimulation blockade, especially the CD40, was developed, but later on Novartis abandoned it because of some side effects. Otherwise, that was developed to prevent both T as well as B cell activation. One can use anti-plasma cells, daratumumab. This has been mostly used in the myeloma literature, not so much in transplant, but there are some papers now to show that it can be used both for the treatment, used especially for treatment of the unremitting antibody-mediated rejection. IL-6, as I talked about, is actually a cytokine which is important for the activation of the B cells and producing of the antibodies. And so one could use IL-6 therapies, that is tocilizumab and other congeners of the same thing. The other is, of course, the plasma cells. If they are active, they can use a protease inhibitor, which can act on the plasma cells. Again, from the myeloma literature, there is a lot of evidence bodies on it. The results in clinical practice are not very encouraging, but yes, there is data to show that it can be used. You can remove the antibodies either by using plasmapheresis or IVA. IVIG tries to fool the antibody. You can develop antibodies to the antibodies and try to eliminate them. And they also have some modulatory effect on the B cells. IDS, as you all know, is another enzyme which is used to actually split open the antibody, and you can damage the antibodies, but you can only give it once. You can't give it again because you develop antibodies to IDS. That is the streptococcal enzyme. Again, you can work at downstream pathway that use eculizumab, which is on the complement cascade, and which you will see more into therapies of this type of rejection. So in summary, if I have to tell you how things really happen in the graft, that you have put in the allograft, the allograft cells as well as the antigens travel to the lymph node, where they are taken up by either by the donor or the recipient antigen presenting cells. They are presented to the T cells. The T cells proliferate, go to the endothelium as well as to the tubule and damage the graft over there. They can then you have a second arm, which is the antigen presenting cells can come in contact with the B cells. Now the B cells can take up these antigens themselves through the receptors. The B cells are helped by the CD4 T cells, that is the anti-follicular helper cells. And some of them are differentiate into the memory cells, and some of them will secrete a large amount of antibody, convert into plasma cells, and secrete the antibodies cause antibody-mediated rejection. These antibody rejections can bring in the complement to damage the graft. Again, important to recognize and just to tell you is that complement are also important for ischemia reperfusion injury, especially the MSP3 pathway is important for the activation of the complement. So complement therapies, anti-complement therapy is sometimes also used to prevent ischemia reperfusion injury. But this, I think, is an overall schema of how the body responds to the allograft which is put in and what we can do about it. So in summary, though one component of the immune system may dominate and lead to rejection, we describe in short as T or antibody mediated. But actually, it is multifactorial, resulting from integration of multiple mechanisms. So it is not that the T and the B cell rejections are separate. They are like the coordinated system where we have the Navy, the ground army support, and also the Air Force. All of them coordinate together. And therefore, India also decided to have a common command. And similarly, we can't really get tolerance unless we understand all the mechanisms, because all of them are going to act together. So identifying the molecular pathways, trigger tissue injury, signal transduction, that is downstream pathways, and rejection facilitate the identification of targets for development of immunosuppressive therapy or tolerance therapy. I will stop here, and if there are any questions, I'll be happy to
answer. Thank you so much, sir. So wonderfully, you have taken us through all aspects of transplant immunology. I would like to ask participants to type their question in question and answer box. Just one announcement. Very soon you would be receiving, might be on Monday, you will receive scientific notes based on today's program. And on Wednesday, we'll give you 2 days to read the scientific notes. And Wednesday, you will be receiving the link for the exam assessment. Please type your questions into the Q&A box.
I can see one question that is curious that splenectomy should help circumcision. Yes, actually, splenectomy was initially done, and it was also promoted by Starzl as a mechanism to reduce the allorecognition. But the splenectomy has several other consequences that it leads to reduced immunity and patients succumb to infections. And therefore, it was thought that it was not worthy to take up splenectomy as a primary immunosuppressant. And because we've got better other drugs, and because you must realize that the greater the degree of immunosuppression that you do, you have the risk of getting infections and your risk of getting malignancies. So though splenectomy initially was thought, it was done, but it was abandoned because it was an increased risk of infection. However, in patients who have an unremitting antibody-mediated rejection, even today, we have noticed cases from especially the centers which do a lot of transplant in sensitized patients. They have shown that if nothing works, they do splenectomy and they do get a benefit from it. I think there are some more questions which I will read to.
Yeah.
Does graft, viral, and bacterial infection induce rejection? Yes, I think it's a very, very important question, because what happens is that once you get a viral infection, especially the CMV infections, all these viral infections, bacterial infections actually upregulate the MHC molecules. So normally a tubular cell or endothelial cell would have very few antennas coming up to attract the T lymphocytes. But once you get a viral or a bacterial infection, these MHC upregulation happens, and more T cells would come to there and then engage into damaging the graft. So there is sufficient evidence in the literature show that patients with getting CMV infection, there's an increased risk of rejection following a CMV infection, and therefore treatment of that becomes important. Similarly with the bacterial infection, UTI, urinary tract infection, has been shown to increase, though not in all studies, but in some studies to show that probably they increase the risk of rejection. So I think it's important to see through it that you don't get viral activations or bacterial infections. Endothelial transcripts, yes, somebody asked about endothelial transcript. Yes, there is a mechanism where right now what people are trying to understand is that how we can detect the rejection process. So as I said, that once the T cell or the B or the antibody engages with the endothelial cell, there are downstream activation of the several damaging transcripts. Meaning, once it goes into it, how does actually a cell die? So a cell dies because either there's a direct damage to the cell, or there are fast ligands, which I didn't, though I showed the diagram, I didn't allude to it much. These are caspases, or what you call as it can undergo or apoptosis. So several of the signatures for apoptosis are activated, and these can be picked up by the transcripts. And Philip Holleran from Canada has done a lot of work on that, and they have a chip where they diagnose activation of these transcripts they use for diagnosis of rejection, which can be more specific and can be more quick also. But it's not widely available. So right now, for most of us, it's not really available. Right? Can blood group A give kidney to blood group B or AB? Which, of course, as I said, that a blood group B person would have naturally occurring antibodies to A. And therefore, A group cannot give the kidney to the B group. But A group can certainly give it to AB because AB would have no antibodies to B or A. And therefore, A can go to AB. And I don't see there's any problem. But if A has to give it to B, either you do a swap transplant or you have to desensitize the patient and then do a transplant. So blood groups are important, and they would be similar method as you would do it for a blood transfusion. The same compatibility is seen. Yeah, any role of non-DSA in ABMR? Yes, as I alluded to, because I didn't talk about the you asked about the non-donor specific antibodies in ABMR. Not really, in the sense that these antibodies are very specific to the HLA antigen. So if you have non-donor specific antibodies, unless they have a heterologous, meaning that these antibodies sometimes may attach to different antigens. Though on the test you may see it to the very specific thing, but in system they may attach to different antigens. If they co-attach different antigens, it may be important. But per se, non-donor specific antibodies are usually not damaging. And therefore, if you have a non-donor specific antibodies, you can go ahead and do a transplant without desensitization. Only thing is that these patients in the clinical studies, they have shown that they may require a little higher immunosuppression, because those who are mounting the non-donor specific antibodies, their bodies might be having a tendency to mount antibodies and something known as heterologous immunity. And you might get an increased risk of rejection. So of course, no antibodies is best. Non-donor specific antibodies, mild problem, but not so much of a problem. And the donor specific antibodies, then yes, you must be careful that these patients will have rejections much sooner and more aggressive. So plasmapheresis essentially the question is regarding the role in treatment or in antibody-mediated rejection or in desensitization. One of the ways is plasmapheresis is actually you remove the antibodies. So either by immunoadsorption or by plasmapheresis. Once you remove the antibodies so that those antibodies are not available to act against the endothelia of the graft. However, because as I said, there are memory cells which continue to produce antibody, you also use, along with plasmapheresis, some B cell therapy or therapy against the plasma cells so as to dampen the further production or continued production of antibodies.
One question is about future pharmacotherapies and targets, potential targets.
Futures is always very difficult to answer, but what is encouraging now is that a lot of therapies, either you can use a therapy to suppress the immune response. And so people are looking at, as I talked something about IL-6. So a lot of IL-6 therapies are coming in for antibody-mediated rejection, and some therapies are coming in, as I said, to remove the antibodies and others. The other therapies which people are looking at is more to do with cellular-based therapies. That is, you can educate the patient that a certain sort of graft is coming. So maybe the future is going to be T regulatory cells or B regulatory cells, so that you get a tolerance. But of course, right now we are not very close to it, but maybe in the future you might get it.
I think you must have addressed this question. Are the diffuse ATNs in immediate post-transplant period risk for future ABMR? It is in chat box. As regards the ATN, whenever you get a delayed graft function, I did show a slide on that. Delayed graft function, whenever you get it, there is an upregulation of the HLA molecules, more antigens are shed, and therefore there's an increased risk of rejection. So ATN is a risk to get rejection, but so that's why what happens is if you have a cadaveric transplant and the patient is not passing any urine and patient has got an urea, it's very difficult to diagnose whether a coexisting rejection is present or not. In such a situation, what we do is that, and most centers will do a weekly graft biopsy. And if you do a weekly graft biopsy and you find that there is a coexisting rejection, you might want to treat it. And because the patient is not recurrently active, it may be because that there is an ongoing rejection also. What is the role of some of the other non-invasive methods? Right now, we do not have much. We do have some, but they're not really enough to supplant a biopsy. Yeah, one more question is about tolerance protocols.
There are several tolerance protocols which are being looked at, but the most work has been done by the Mass General Hospital, where Kawai and they have shown, and most of them, there are two ways. One way is to develop a mixed chimerism. And historically, if you go back to the history of transplantation, the first thing was about the pre-Martin cattle, where there was a chimerism and they could exchange the skin. Then there was a neonatal tolerance induced by Medaver, where you can, when you put antigens in the neonatal period, you get tolerance to it. So a similar strategy was thought of by the MGH, and they have good animal experimentation for mixed chimerism. And they have shown some patients of mixed chimerism who have really lived long without immunosuppression. So I would encourage that if you want, you can read the literature on that. But most of the other protocols people are trying to use now is that a combination of sirolimus with belatacept and maybe an ATG, but they are not still available in the clinical realm but they are more investigational. People have tried total body irradiation and then doing a bone marrow transplant, not completely myeloablative, partially ablative, and then do our thing. But many of these protocols are working sometimes in the hands of investigators, but they're not available for routine use. So right now, I think that space is very active, but doesn't look like in the immediate near future we will have therapy more widely available.
DSA monitoring, any guidelines?
Generally, there are two things that if you have whether you have a sensitized patient or you do not have a sensitized patient. Sensitized patient meaning those who already have memory to the HLAs and they would have antibodies in them, and you have gone ahead to do a transplant across the HLA antigens. In that event, you would have require very close monitoring because you use a desensitization protocol. And in that event, actually the recommendation to do a weekly DSA to see if the antibodies are going up and to treat it. In patients who are naive and do not have pre-transplant donor-specific antibodies, these, as a protocol, it's not currently recommended that all of them should undergo it, but centers which are more academic centers and want to look at it very carefully, do it at 1 month, 6 months, and 12 months. Because it is expensive to do a donor-specific antibody testing, it costs in our country about 35,000 rupees. We generally tend to do it on a need basis. On a need basis, meaning whenever the creatinine goes up, we would do a donor-specific antibody, do a biopsy, do all the tests to know whether they are involved or not. And if you treat the patients, then it is shown that the response to the antibody-mediated rejection, one of the defining features is the reduction in the antibody titers, and of course the improvement in the graft function. So those who have reduction in the antibody titers, and they are likely to improve. And again, as I said, it is expensive, so we don't routinely monitor it. But in some patients where the response is not there, we do it and see if it requires more therapy or not. But even in the clinical practice, even in the West, they don't routinely monitor unless as a part of an academic center that they would do it for research purposes.
We'll take this last question. Any protocol to monitor ABO titer after immediate post-ABO incompatible transplantation?
The general people who are the experts in the field of ABO incompatible transplants don't really recommend to monitor the ABO titer because they feel that usually things will go good. But if you're initiating a program and you want to be very careful, you can monitor it on day 1, day 3. Usually the engagement of in ABO incompatible transplant, their first 15 days are where we say that either you develop antibody rising titers and you might lose a graft, or you develop accommodation. Some centers, they would monitor the ABO titers, and if the titers are going up, that is a doubling of the titers or quadrupling of the titers, that they might introduce a session of plasmapheresis or 2 sessions of plasmapheresis. In our center, we don't routinely monitor the ABO titer, but if there is a problem, we do monitor. Sometimes I would do it if a patient has a very high pre-transplant titers and we have had a very difficulty in getting the titers down. In such patients, I would monitor the titer. And then, as I said, if it is rising titers, then we might do an additional plasmapheresis.
This is last question, I would say. We'll not take for more questions. How frequently we monitor DSAs post-transplant if has pre-transplant DSAs?
If a patient has a pre-transplant DSA and if you have instituted a desensitization protocol, I think it is recommended to monitor weekly. But with the cost consideration, we might at least do it once in 2 weeks to see if the antibodies are coming back and want to intensify the immunosuppression or give them an additional session of plasmapheresis. In our center, we don't do too much of desensitization. but whenever we have done, especially for second transplants and things like that, because of the cost considerations, don't routinely monitor, but if things are not looking good, I would do it at 15 days and then 1 month. And if they do come up and if they have clear treatment, then maybe more frequent.
We're at the fag end of our session. So I have just shared our email ID with you. You can, if you have any questions, you can get back to us on mangesh.balerav@rpgls.com. It is there in the chat box. You can definitely contact us. We'll share those queries with Dr. Shishir sir. So you will get appropriate answers for that. So, so what's your concluding remarks for today's podcast?
I think I would like to thank all of you for coming in on a Friday evening. I know it's a busy day for all the students and the beginning of the weekend. And it's always nice to interact with you and for the lovely questions that you posted. And I'm sure, I don't know whether you benefited or not, but I hope that you benefited from this talk. And I'd like to also thank Dr. Mangesh for getting us all together, and hope to see you again in future, maybe sometime more in a live session rather than online, because live is always better. We like to see the face of it.
Yeah, definitely, sir. We are committed for physical and live sessions, and there are more to come. There are almost 7 sessions plus 2 on demand of PGs are waiting for them. So definitely we'll have more opportunities. So once again, I would like to thank to all participants and today's honored speaker, Dr. Shishir sir. I would like, please stay tuned with us for next week. We'll be sharing with you the first scientific notes. Then you will be getting the assessment, the link for the assessment, and definitely you would be getting the video recording of this session as well as past 2 sessions. So thank you so much. Have a great weekend. Thank you.
Thank you. Bye-bye.